Hey everyone, welcome back to Shock Doc Medical. I'm Dr. Rod, and today we're diving into something that might just change the way you think about that pesky itch. Yes, I'm talking about pruritus in patients with no underlying skin disease. Have you ever wondered why you sometimes feel an unbearable itch even though your skin looks totally normal? Or how this invisible itch can wreck your quality of life just like chronic pain? Well, buckle up, because we're about to get into the nitty-gritty of this fascinating topic. All right, so here's the deal. Pruritus, or as most of us just call it, the itch, is that annoying sensation that makes you want to scratch like crazy. And get this, it's not just a minor inconvenience. In fact, when it sticks around for more than 6 weeks, it's classified as chronic and can really drag down your quality of life. Studies have shown that chronic itch can impact your sleep, mood, even lead to depression, much like chronic pain does. That's huge, right? Let's break it down. Pruritus is the unpleasant sensation that makes you want to scratch. It's a major symptom in a whole host of diseases, both those that affect your skin directly and those that mess with your body in other ways. And guess what? It can be mild and intermittent, or it can be severe and stick around for the long haul. Now, the International Forum for the Study of Itch came up with a neat clinical classification for pruritus. They divided it into 6 categories based on what's causing the itch. Dermatological. This one's pretty straightforward. Itch that comes from skin diseases like atopic dermatitis, allergic contact dermatitis, xerotic dermatitis, lichen simplex chronicus, lichen planus, scabies, or urticaria. These usually have visible skin changes. Systemic. Here, the itch is linked to diseases in other organs. Think liver issues, kidney problems, or disorders of the blood-forming system. Neurological. This type stems from issues in the nervous system, either central or peripheral. Psychogenic psychosomatic. Sometimes the itch is tied to psychiatric conditions. It's not just in your head, it's very real, but it's linked to mental health. Mixed, a combination of any of the first 4 categories. Other. And then there's pruritus of undetermined origin, where we just can't pinpoint the cause. Now, with categories 2 through 6, you often don't see any primary skin lesions at first glance. But over time, with all that scratching, you might develop secondary lesions like excoriations, prurigo nodularis, or even lichenification. And trust me, that can make things even worse. Let's talk about the different culprits that could be causing this chronic itch. I promise it's like assembling a puzzle, and every piece matters. Systemic disorders, renal failure. If you have end-stage renal failure, 15 to 48% of those patients, and up to a whopping 90% of those on hemodialysis, experience pruritus. It tends to be generalized, peaks at night, and interestingly, often resolves after a kidney transplant. Hepatic disorders. Up to 80% of patients with primary biliary cirrhosis get hit with itch. Plus, conditions like primary sclerosing cholangitis, choledocholithiasis, bile duct carcinoma, and various types of cholestasis can cause it. And ladies, pruritus of pregnancy, known as pruritus gravidarum, happens in 1 to 8% of pregnancies, usually starting in the 3rd trimester and resolving after delivery. Thyroid disease. Hyperthyroidism can lead to a more severe, generalized itch, while hypothyroidism might cause localized itch, often due to dry skin. Diabetes mellitus. Roughly 7% of diabetics might experience itch, especially in the genital and perianal areas, possibly due to neuropathy or infection. Infections. HIV/AIDS. Sometimes pruritus can be the first sign of HIV infection. Patients might develop it without other skin issues, and its severity can even correlate with viral loads. Elevated IgE levels and peripheral eosinophilia might be clues here. Hepatitis C. Around 15% of chronic hepatitis C patients experience itch, either generalized or localized. Parasites. Various parasitic infections like ancylostoma, tungiasis, schistosomiasis, myiasis, and trypanosomiasis can cause either a localized or generalized itch, often accompanied by other skin findings. Hematologic disorders. Myelodysplasia. The prevalence isn't clear, but it can present with either generalized or localized itch, and sometimes as aquagenic pruritus. Iron deficiency. This isn't just about fatigue, it can also cause itch, which may be a sign of an underlying malignancy. It can be generalized or localized, especially around the perianal or vulvar regions. Polycythemia vera, PCV. About 30 to 50% of patients experience itch here, And sometimes the itch, particularly after water exposure, aquagenic pruritus, might show up even before the diagnosis. Hodgkin's disease. Around 30% of these patients have persistent generalized itch, which can be a bad prognostic sign and might even predict recurrence. Tumors. Solid organ tumors. Sometimes itch might even be a harbinger of cancer. It occurs in 5 to 27% of patients in palliative care and is often generalized, although its intensity doesn't necessarily correlate with tumor burden. Carcinoid tumors. These are interesting because patients can experience itch during flushing episodes, mostly affecting the upper half of the body. Drug-induced itch. Virtually any drug can cause itch. Think antihypertensives, antiarrhythmics, anticoagulants, anti-diabetic drugs, hypolipidemics, antimicrobials, chemotherapy agents, psychotropics, antiepileptics. The list goes on. The mechanisms vary from cholestasis and hepatotoxicity to simple dry skin or histamine release. Neurologic causes. Conditions like brachioradial pruritus, multiple sclerosis, postherpetic neuralgia, notalgia, or meralgia paresthetica can lead to localized itch due to nerve damage or irritation. Sometimes, deficiencies like vitamin B12 or even diabetes can play a role. Psychogenic psychosomatic causes. Sometimes the itch is more about the mind than the body, seen in conditions like delusions of parasitosis or psychogenic excoriations. These can be generalized or localized, and it's crucial to rule out other causes here. Mixed etiologies. For example, you might see uremic itch combined with xerosis, or a patient with HIV might have both neurologic and dermatologic reasons for itching. Other categories. Pruritus of the elderly. There are a ton of factors here, from chronic disease and polypharmacy to age-related skin changes. Aquagenic pruritus. This one's super specific. It happens within 30 minutes of water exposure, lasts up to 2 hours, and interestingly, spares the head, palms, soles, and mucosa. Pruritus in anorexia nervosa, though its cause is unknown, it tends to resolve with weight restoration, but can be intermittent or constant, often localized to areas like the neck, thighs, and forearms. So, how do we actually diagnose something that can be caused by so many things? It all starts with a really detailed history and physical exam. You've got to dig into the patient's medical history, medication list, and any subtle clues that might point us in a direction. Sometimes, we even need to get our hands dirty with a skin biopsy, run a battery of lab tests, or even order imaging studies. Let's talk specifics. When evaluating pruritus, we often start with a complete blood count CBC with differential. This helps rule out issues like leukemia, myeloma, iron deficiency anemia, or even infections like HIV. A chemistry profile, checking liver function tests, AST, ALT, ALP, and total bilirubin to catch any signs of cholestasis or hepatitis. Kidney function tests, creatinine and blood urea nitrogen are key to identifying uremia. Thyroid function tests. We need to look at TSH and reflex-free T4 to rule out thyroid disease. Chest X-ray, sometimes used to check for lymphoma or lung cancer. And if needed, additional tests might include sedimentation rate for inflammation, glucose for diabetes, detailed iron studies, serum protein electrophoresis for myeloma, and a host of other antibody and imaging tests. The idea is to leave no stone unturned. Now, let's talk about how we manage this beast. The neurophysiology of pruritus is insanely complex, like trying to untangle a giant ball of yarn. But understanding it opens the door to some pretty targeted treatment strategies. First off, if there's an underlying condition, correcting that can sometimes do wonders. For example, if the itch is due to iron deficiency, treating the deficiency might help reduce the itch. For symptomatic treatment, there's a bunch of options. Now, remember, I'm not prescribing anything on the fly here. Always consult your doctor for what's right for you. But here are some of the therapies mentioned in the literature. Topical treatments. Emollients. These are your go-to moisturizers, often used liberally to soothe dry, itchy skin. Topical capsaicin. This can help by depleting substance P from nerve endings, usually applied in a cream. Topical lidocaine acts as a local anesthetic to numb the area. Topical calcineurin inhibitors or corticosteroids. These reduce inflammation. Typical corticosteroid creams might be applied twice daily, but the specific dose really depends on the strength and formulation. Oral antihistamines. Both sedating and non-sedating types are used. For example, diphenhydramine might be given at 25 to 50 milligrams at bedtime, while a non-sedating option like cetirizine is commonly used at 10 milligrams once daily. Light therapy. Narrowband or broadband UVB can be effective in some cases. Other systemic treatments. Depending on the underlying cause, treatments can also include anticholestatics, antidepressants, anticonvulsants, thalidomide, or even opioid inhibitors. These are typically tailored to the patient's specific condition, so dosing can vary widely. Look, folks, this isn't just academic. For many patients, chronic pruritus is as debilitating as chronic pain. It messes with sleep, mood, and overall quality of life. And for doctors, being able to pinpoint the cause of an otherwise invisible itch can be the key to effective treatment. It's a reminder that sometimes what seems like a simple itch can be a signal of something much more significant happening in the body. I find this area of medicine absolutely fascinating. It's where the art of diagnosis meets the science of treatment. And whether you're a fellow healthcare provider or just someone curious about how our bodies work, there's so much to take away here. All right, that's a wrap on today's deep dive into pruritus in patients with no underlying skin disease. I hope you enjoyed this deep, information-packed episode and that you now have a clearer picture of how complex and crucial this issue is. If you found this episode helpful, please hit that like button, subscribe to ShockDoc Medical, and drop your thoughts or questions in the comments below. Let's keep this conversation going. And hey, stay tuned for our next episode, where we'll uncover yet another groundbreaking discovery that might just change the way you see medicine. Until then, keep questioning, stay curious, and take care of yourself. This is Dr. Rod, signing off. Thanks for joining me on ShockDoc Medical. See you next time.